very much, Jaffer. It's a pleasure to be here this morning. It's an important time, I think an important part of the year. We're going into a World Health Conference in a couple of weeks, and then we have a cancer conference coming up, and of course, it's the biannual conference on HIV and AIDS, all of which will take place later this year in Melbourne, Australia. So it's important to come together and to recognize what we can do together to look at the increasing burden of both HIV and NCDs in the world. You might wonder why somebody from the American Cancer Society or why the American Cancer Society itself is up here talking about global health. And I think the answer to that question is because we simply must be. We've already seen from the speakers who have spoken this morning that we have a coming tsunami of cancer and other NCDs in the world. And one of the things that we have to offer is 100 years of experience in fighting one of these NCDs, namely cancer, and also a grassroots network that has been very involved, that understands what cancer is in the United States and can be mobilized to do something about cancer in other parts of the world. We are making some progress in the United States, primarily through primary prevention, but also through better treatment and earlier access to treatment. But that's not true in what's going on in the rest of the world. So we embarked earlier this year on a new global strategy to look at how we can leverage what we've learned in the United States about helping people to stay well and to get well by finding cures and by helping them fight back, to address the same kind of work we do in the United States in the global arena. As this graph shows, and you've already heard about NCGs in general, but this is about cancer in particular, that about 15% of all the global deaths are due to cancer. And according to the World Health Organization's report released earlier this year, the IARC report, in 2012, we had an estimated 14 million new cases of cancer a year and about 8.2 million deaths from cancer in 1 year alone. And that's projected in the next 20 years to rise to 22 million new cases of cancer a year and 13 million deaths. So as we can see, this is already eclipsing what has happened in the AIDS world over time. Where are these cases occurring? Well, more than 60% of the total cases are occurring in Asia, in Africa, in Latin America, and the Caribbean. And over 70% of the world's cancer deaths are occurring in these regions of the world. And the difference in the amount of new cases, the amount of deaths, is poorer access to early detection and poorer methods of treatment that are available. So the cancer experience we know in low-income countries is very different from the experience in the United States, the UK, and other high-income countries. More than 80% of the patients are presenting at very late stages in cancer, stage 3 or stage 4. And so some of the advances we've seen in cancer survival in the United States and other countries are not reflected in the experiences of people in the developing world. It's a fact that half of all the cancer survivors in the world today live in the United States, although we are only 11% of the cancer incidence in the world. But the effects of cancer on the world are not only in health, they're also economic. The costs of the cancer burden are damaging the economies, even in countries like our own. And they're certainly far beyond the reach of developing countries to deal with at this moment. It's placing increasing and impossible strains on healthcare systems. Back in 2010, in advance of the high-level meeting, some research done by the World Economic Forum placed the total annual cost of cancer at approximately $1.16 trillion per year. And chronic disease as a whole could cost the world $47 trillion in lost economic output over the next 2 decades. And to put that in perspective, that's 75% of the whole global GDP in 2010. So if we could do something about that cancer burden, we could actually eradicate $2 a day poverty among the 2.5 billion people who are living in that state for more than a half a century if we could just do something about the cost of NCDs. To hone in on our thoughts more about HIV and cancer, and particularly, which is why that we're here to discuss today and what we can learn from each other. It's clear that cancer, just like cancer and mental illness and cancer and or mental illness and HIV and cardiovascular disease and HIV, cancer and HIV have a very close relationship. They're connected in a number of unique and interrelated ways. We know that cancer is actually the most common AIDS-related disease, and the people infected with HIV are several thousand times more likely than uninfected people to be diagnosed with Kaposi sarcoma. They're at least 70 times more likely to be diagnosed with a non-Hodgkin lymphoma. And if you're a woman, you're at least, and HIV positive, you're at least 5 to 10 times more likely to be diagnosed with cervical cancer. And they're also at risk of a number of other, higher risk at a number of other cancers as well, including anal cancer, liver cancer, lung cancer, and Hodgkin lymphoma. My friend Moffat already told us why that was the case for cardiovascular. It's very much the same thing for cancer diseases. It's both the HIV causing changes in the body itself, and then the treatment with ARTs can also have significant side effects that increase the likelihood of developing a cancer. And also, there are some risk factors that make it more disproportionately common. Urban sub-Saharan Africa, actually, obesity levels are now equal to those in Western countries. And according to UNAIDS, more than a third of the individuals who were screened at HIV testing sites were obese and had high blood pressure. And there's also, and this relates to mental health, I think, as well, that between 40 and 70% of HIV positive people are smokers. And fewer are likely to engage in smoking cessation programs than HIV negative populations. So we know also that cancer is coming to HIV positive populations because they're living longer. We've learned some lessons in HIV, and that's what I want to talk about this morning. First of all, I think if you can remove the stigma around HIV or the stigma around cancer, you can save lives. And this elephant is meant to show us that 20 years ago, HIV/AIDS was the elephant in the room in the developing world. And nobody in those days wanted to be tested for HIV because there wasn't really any effective treatment out there. And people died without ever being diagnosed for HIV. And in 2 decades, there's been a tremendous change in terms of HIV in the world, and we've made voluntary counseling and testing available to people all around the world, and we've put treatment options out there for HIV and AIDS that have made a real difference. So people are getting diagnosed earlier, and that means they're living. But today, I would say that cancer is the elephant in the room. People don't even want to talk about it. The places that I go in Africa, they fear cancer much more than they fear AIDS because there are treatments out there for AIDS and there are no treatments out there for cancer. So I brought the elephant along with me. And the elephant in the room today is really cancer. People aren't getting preventative screenings. The cancer is often misdiagnosed as something else. And when it is diagnosed, it's too late for effective treatment, even if people have access to it. So we know that prevention is essential, and lots of cancers are preventable. And I think the most important thing that we can do about prevention is to do something about tobacco control. And that's something that hasn't yet been mentioned here this morning. Tobacco is poised to kill 1 billion people in this century if left unchecked. Many of those are children as yet unborn. And the vast majority of those people will be in low and middle income countries because that's where 80% of the smokers live. So it is the single most preventable cause of death. And it's the only risk factor which is common to all 4 of the major types of chronic disease, causing 1 out of 6 deaths from non-communicable diseases. And Africa in particular is slated to become the future epicenter of the tobacco epidemic, according to a report recently done by the American Cancer Society. We know that the number of Africans who smoke could increase to a staggering over 500 million by 2100, from 77 million today. So today, Africa has lower tobacco rates, lower smoking rates than anywhere else, any other continent in the world. But it's largely unprepared both to deal with the onslaught from the tobacco companies and with the resulting increases in lung cancer, other kinds of cancer, and other NCDs if smoking really takes a hold. So I think if we do nothing but stem the rising tide of tobacco use in low and middle income countries, particularly in Africa, we will have done a tremendous amount. The other area that I would focus on is cervical cancer. Cervical cancer is the third most commonly diagnosed cancer in women, with 530,000 cases and 275,000 deaths in 2008. And the burden of this is 90% in the developing world. India alone represents 26% of the deaths from cervical cancer. And the tragedy is that this is happening even though we know how to prevent and to treat cervical cancer. And we aren't seeing the progress. We have both a vaccine for cervical cancer, we have HPV vaccine. Now, can you imagine if we had a vaccine for AIDS, how much the whole world would be shouting about, we have a vaccine for AIDS. After 20 years of research, we have a vaccine for AIDS. Everybody in the world needs to be vaccinated against HIV. We've had an HPV vaccine for over 6 years now. In fact, we have 2 vaccines. They're effective at preventing over 70% of cervical cancers. They are being introduced in many countries around the world, and yet even in countries like the United States, we have a 30% vaccination rate. So I think there's a tremendous amount that we can do in getting access to HPV vaccine everywhere in the world and to make real progress on immunization programs. And we've got a double weapon against cervical cancer because not only do we have a vaccine, but we have an effective screening method. As we know, in this part of the world, we've had the Pap smear for 50 years. It's been tremendously effective at getting people into early screening, resulting in early diagnosis and a survival rate of over 90%. What we have now in the developing world is 2 really important progresses in cervical cancer screening. The one is VIA, which is looking at the cervix after putting acidic acid on it. We can detect early lesions and they can be treated on the spot with cryotherapy. So to integrate that screening method into reproductive health and HIV around the world is something that's being HIV screening and reproductive health clinics is something that has only begun to start, but it's very important. And the other new, beyond Pap smears, and I think the most effective way to sort out HPV is to do a DNA test for HPV. And that's also coming down in cost and becoming very much more affordable and available all around the world. So there's a lot that we can do about tobacco prevention. There's a lot that we can do about cervical cancer prevention as well, and to raise the awareness about these things. I think we need to tear down our disease silos. We need to be preventing obesity. We need to be showing healthier diets. And we also need to be doing more about treatment. Treatment has been like HIV treatment 20 years ago. We said it's just not possible to treat for cancer in low-income settings. I think that's a mistake, and we will be overlooking the opportunities that we have. We know things like Burkitt's lymphoma are enormously treatable. So is treatment for some kinds of breast cancer. And certainly so is treatment and palliative care, or treatment as palliative care. To diminish suffering and offering pain relief is to increase the quality of life. We know that the best medicines for effective pain management are opioids, and we also know that they're on virtually the essential medicines list of virtually every country in the world. And yet 85% of the world's population living in lower middle income countries consume just 7% of the opioids in the world. And the great majority of people who are dying, whether they're dying from HIV or AIDS or dying from cancer or dying with cardiovascular diseases, are dying in pain. And this is something that does not need to happen. And so one of our programs at the American Cancer Society is called Treat the Pain, and we're working with ministries of health to make oral morphine available to patients who need it. And we expect to continue this work in Africa, in Haiti, and in India over the next few years, and I think this will make a tremendous difference. Finally, I think what we need to do as a community around the world is to do better advocating for money to be spent on NCDs around the world. In the United States, we often say that the cancer fight is as much an issue of public policy as it is of medical and scientific challenge. And that's true nationally and regionally and globally. Advocacy is really a force multiplier. And today, modern grassroots advocacy was really born from the HIV advocacy movement. And we need those of us in the cancer control community and every other grassroots organization to learn from what they learned in HIV. And I think in some ways that's to get more active, more vocal, more angry about what's happening, and to involve civil societies in developed countries and developing countries. So we need to advocate for more resources, and that has to come locally from national governments, but it also has to come internationally. As being one of the founding members of UNAIDS in 1995, it took quite a long time for the shift to come and for the resources to grow from, as it was mentioned this morning, from the millions or hundreds of millions to the billions. Today we're in a situation where there's terribly inadequate funding for NCDs in the world. There's $24 billion in assistance for health, and only 268 million, 1.1% of that is allocated to NCDs. So through these conferences this year, I think we need to be advocating with foundations and governments and the private sector to be looking at a whole of government approach to make sure that it's not just the health ministries, but the finance ministries, the trade ministries, and the prime ministries of countries around the world who recognize what's happening to their populations from NCDs, and to be doing a better job to fight back. We know it's not only a health risk factor, but it's an economic risk factor which will destabilize families and communities and nations. So I think it's very clear that it's a huge issue. Cancer alone is a big issue, and cancer and the other NCDs provide a formidable challenge. But the good news was we know how to save more lives, and we know how to save them now. And we can create a world that has less cancer and, as we would say, more birthdays. And if we come together to implement proven strategies and find new ways to break down the barriers that hinder our progress. Because where you live shouldn't determine if you live, and it's a matter of dignity, equity, and human rights. And that's what we're here to discuss today, and I look forward to the discussion on this panel and to the rest of the day's proceedings. So thank you very much.